All right, we're going to start here on, it says it's chapter 18. I forget which one it is in your book, but that's the digestive and urologic emergencies, what we're going to start with. All right. So basically, what this slide is saying here is that basically you need to look out for GI bleeding. That's pretty much the only thing that you're going to really be able to treat. And as in treat means reverse signs and symptoms of shock. We normally do trauma first, or at least I've always done trauma first, and you would be able to know what that is, but at this point you probably don't. But when we get to shock trauma, which I believe will be next semester, we'll go over shock treatment. But GI bleeding, or it's just like any other bleeding, you've got to take care of it. The only problem is that the GI tract is so big and so long that if you've got a really nasty bleed or a very fast bleed, you can literally have a person go into shock and into cardiac arrest. I've seen it done without actually being able to find the source of the bleed. They'll have a bleed, and the only thing that you'll really be able to suspect is they've got a gastrointestinal bleed. We'll talk about all this stuff as we go. We'll talk about all this stuff also as we go. Abdominal pain is truly a common complaint. You will get called for abdominal pain. The thing about abdominal pain is that it's a vast variety of what could be wrong. There are some signs and symptoms of things that you should be able to narrow down some things, but really, honestly, the only thing that we can do, as far as in the field, is do pain management. For the abdominal pain. Pain management and treat any shock symptoms, give them IV O2 transport. That's pretty much all you really can do when it comes to abdominal pain, except for treat the actual pain itself. You're not going to be able to find out where it's at or do anything like that. So really what your job is to just kind of manage the patient and get them to the appropriate center that they need to be treated for. We'll talk about the abdominal cavity. So they want to point out right now there's solid and hollow organs. Solid organs are your liver, your spleen, your pancreas, your kidneys, and the ovaries. Injuries to any of these, especially if you got blunt force trauma, which again we did not go over, but blunt force trauma is basically where you're hit with something. That's blunt force. So if you're hit with anything, whether it be in a car wreck or anything of that nature, these are very vascular. They're very vascular, meaning that they have a lot of blood flow go to them, and any tear in that can actually cause internal bleeding. The thing about the abdominal cavity too is it's a big, huge space. You can hide a lot of blood very easily without having any real signs and symptoms of it. So one of the things we'll look for is when we talk about shock trauma again is abdominal bleeding from blunt force trauma. These are your hollow organs. What you're really worried about with these are the fact that they're pouches. They hold things. And since they are pouches, they can rupture. If they do rupture, the contents that they have will leak into the abdominal cavity. Going into the abdominal cavity, if it's not just air or space, nothing, or normal saline, which we'll talk about that here in a little bit, but basically anything in the abdominal cavity itself will cause issues and problems. So you want to make sure that all of these hollow organs contain the material that they have inside of them. Here's the diagram of those. You can see these are the solid organs. These are the hollow organs. I'll let you review that on your own. So we're going to start at the very beginning of the digestive tract with the mouth. The mouth has saliva glands that produce this like liquidy material that actually has like digestive enzymes in it. So you literally start digesting food the moment you put it in your mouth and chew. So you put it in your mouth, you start chewing, that starts digesting. One of the things, too, that the saliva glands do is they provide lubrication for swallowing. That's very helpful because sometimes the esophagus might be dry. The esophagus itself is it's closed and flat clamped down together. It's not a solid tube like the trachea. The trachea has the cricoid rings in it that hold it open. The esophagus is not held open with anything. So that's why it helps to have some sort of lubrication to swallow with. There you go. There's a picture of the saliva glands in relative area to the pharynx, the esophagus, and into the stomach. One thing that you need to take notice of is the actual anatomical location of the esophagus. It's about 8 inches long. The tissue is called mucosa. That lines the inside of it. and it's behind the trachea, but in front of the spine. So that's very important anatomically, especially if you were to do, when we start talking about supraglottic airways and you're able to put an airway in, you will literally be putting the airway, part of it, into the esophagus to block the esophagus off and actually breathe into the trachea itself. All right, something called peristalsis. Peristalsis is very important. Starting with the esophagus, when you swallow food, even in the stomach, there's something called peristalsis. Basically, it's wave-like contractions. So what you have is you have a food bolus. Whatever you swallow is called a food bolus, or in the stomach, put together, it's called a food bolus. It enters into the esophagus and also into the digestive tract. It doesn't matter where it is. You have peristalsis or peristaltic movement. The musculature that's in the esophagus or in the intestines or the colon, wherever you're at, will squeeze. And when it squeezes, it pushes this food bolus forward. This section relaxes wherever it's at. So what you have is this wave-like squeezing motion of like just pushing it down and in. So that's what you're trying to do. Have that happen is you're having the peristaltic movement take and move the food or the food bolus to be absorbed or digested for whatever reason. The peristaltic movement is how everything moves through the digestive system. It's very important to understand that. So one of the problems that you can have with the esophagus is called esophagitis. Basically what happens is you have excessive acid in the stomach, and we will talk about that here in a minute, but that acid can reflux and come out. If you have too much acid, it's got to go somewhere. It doesn't go forward, it goes back up. So if you have heartburn or anything like that, that's typically what that is acid reflux. Acid reflux is actually a lot more serious. It's also called GERD, gastroesophageal something disorder. I have to look that up. I'm sorry I didn't prepare that, but you still have the acid that reflux in. What happens is it actually will burn the lining of the esophagus. When it burns the lining, it starts actually marring it and causing for disruption, or like it could actually cause breaks inside of the actual lining or the mucosa. So it causes irritation. You can have pain on swallowing, vomiting, and you can have sores in mouth depending on how far this goes up. So that's esophagitis. There is something called Mallory-Weiss syndrome, or what they really call a Mallory-Weiss tear. What happens is you actually, when you swallow down, you put the food into your stomach. In the event that you do become nauseated and vomit, what happens is if you have too forceful of a vomit, if you're vomiting very hard, or you're retching and there's a lot of food that's coming back up, if it's too much, it could actually cause a tear and start bleeding into the stomach. That's what a Mallory-Weiss syndrome is the fact that you can have these Mallory-Weiss tears and cause bleeding, and it's typically from vomiting. When you vomit too forceful, too hard, that is why you get one of those tears. The correct term for vomit in blood or vomiting blood is hematoemesis. Hematoemesis. Basically, it's blood vomit. So if you're vomiting up blood, let me just tell you right now that if there is any bleeding into the stomach, whether from a Mallory-Weiss tear, a nosebleed, a lot of people used to preach tip your nose back and swallow. That is wrong. If you're treating a nosebleed, you want to have them lead forward and spit it out or let the blood drain out. When we get again into shock trauma, we'll worry about how to stop a nosebleed. But if you swallow blood, it is called a natural emetic, meaning that it is natural to the body and it causes irritation in the stomach that causes vomiting. So sometimes that scares people when they have a nosebleed. They'll tip their head back trying to stop the bleeding, which is bad because it'll let it drain. What you want it to do is you want to tip forward and let it pool up in the nasal cavity and clot off. So forward is better. But if they tip their head back, they're wrong. And if they're swallowing it, they're more than likely going to get an upset stomach, or they're going to throw up blood at some point. I kid you not, a little bit of blood will indeed cause vomiting. All right, the stomach. It's a sac-like structure. It's got some layers of musculature. The layers of musculature actually take and they churn. They'll contract and churn all the food that's come down. and they'll store the food as they prepare it. So the function of the stomach is it has this rugae in it. So inside, there's the layers of the stomach. Let me see if I've got those. Nope, I don't. But there's layers to the stomach, and they have that musculature, and then there's a lining inside. The lining is kind of built up like this right here, and it's called rugae. And the rugae, however you want to say it, has inside of it proton pumps, and that proton pumps produce acid. They're going to kick out the acid, and they cause an acidic environment inside the stomach, and it starts breaking down food. And it creates something with the food mixture and the acid together. It's called chyme. And chyme is simply just the mixture, or the mixture of the acids and the food together. And what happens is you've got the pyloric sphincter. It remains closed. And after it gets to a certain digested level or a certain acidic level, this pyloric sphincter will relax and will strain into the small intestines. So what you're throwing up, typically the first time, is going to be this chyme. It usually is still in your stomach. If you do wind up vomiting or having emesis, you will throw up this stuff. So you can get ulcerations or penetrations in the rugae, just like you can have it as gastritis. You can have it. You can have ulcerations, and all that means is there's a break in the actual rugae that protects the acid. That rugae has that protective layer of acids, or protects the acid from the actual rest of the stomach, and the musculature that's around the stomach that causes help digestion. So what happens is you get a hole in that, and it starts, actually the acid starts eating through the muscular wall of the stomach. Now, they can go away, they can heal on their own, but it can cause definitely bleeding, and depending how long or how severe or how significant it is, it could be an issue. We will talk about stool coloration and what that really means, and some blood in the vomits. That can happen as well. But basically, really, ulcerations, you're going to have the heartburn sensation. They're gonna feel that. They're gonna have that. So it may not be a true emergency unless the bleeding has got so severe that they're in shock. But there you have it. There are those are your signs and symptoms. But you can have ulcers in the stomach. So some of the things that assist with digestion. One of the things is the liver. The liver is a big bad dog in digestion and just in the body itself. It does a lot of things. One of the reasons why I won't eat liver is because everything passes through the liver to be turned into something else. So, and usually you have a bunch of toxins in livers from that converting thing from one thing into another. One of the things that the liver does do, though, is secrete something called bile. Bile emulsifies fats. What basically means is it helps break down fats. So, if you eat a fatty meal, you want to have a lot of bile. The gallbladder is right up underneath the liver. It is the reservoir for the bile. So excess bile that gets made, it's being made constantly. It's being made 24/7. What it'll do is it'll store it into the gallbladder. And it looks like this. Basically, you have this common bile duct. So it gets made in the liver, it comes down. I really don't think the gallbladder sits like that because I'm sure it sits more like in an angle where the excess bile will come in and drip into it. And then what happens is that if you do eat a fatty meal, your body senses it, and it'll go ahead as it releases into the chyme into what this is called the duodenum or the duodenum. So it releases the pyloric sphincter into here. It will contract this down, and it'll release the bile into this common bile duct and start mixing it in the duodenum with the chyme. Bile is, again, like I said, it just emulsifies fats. So you can have fat-soluble vitamins, and it comes down that common bile duct. Another thing that the liver does is it has glycogen stores. Glucose is the main energy source for all our cells. Remember, the cells love oxygen and they love sugar. But what happens is if you get too much sugar in the body, the liver's like, hey, I got this. I've got all this storage area. Let me go ahead and turn this into glycogen. And it will store glycogen in the liver. So if there's an event that you wind up having a fast, like say, for instance, you get sick and you're not eating, that's okay. We've got all these stores backed up and we can go ahead and do that. one of the things that we do for our diabetic patients, if we can't get an IV on them to give them the D50, or the glucose water basically, is we'll give them something called glucagon. Glucagon is what releases the glycogen stores. So you can actually bump somebody's sugar up by actually having the glycogen stores in the liver released into the bloodstream, and you have to use glucagon as the key to release that. But your body makes glucagon normally and naturally anyway. So if you go on a fast, that's the beauty of the glycogen stores. The pancreas. Pancreas is that long organ. It actually has two functions. It has an endocrine function, which we'll discuss later, and it has an exocrine function. What it does is it creates also additionally enzymes that have like a digestive juice cocktail, if you will, that get put into the small intestines along with the bile. If you'll notice that in here, in this area, it'll do all its endocrine functions, but the exocrine functions, or the digestive juices that it has, will also come and it'll mix with the bile, and it'll go in the duodenum or the duodenum, however you want to say it, right here. So you got the chyme, you got bile, and more digestive juices all coming together, and it's all to help aid in the digestion and absorption of nutrients into the body. All this is set up to do that. The common bile duct, again, is something I wanted to point out and stress that there can be issues that happen and go wrong in the common bile duct. One is something called cholecystitis. Cholecystitis is basically you have an issue with the gallbladder. It's inflammation. Itis is inflammation. The chole is gallbladder. Typically, what it can happen is from gallstones. You can have these gallstones build up and get stored into the gallbladder itself. What happens is remember, when you eat something fatty, the gallbladder will contract and push out the excess bile into the common bile duct. From there, though, if you've got a stone, it may pick up and catch and throw a stone. And you can have them get lodged anywhere depending on their size. So that is bad juju. I've had this happen to me and had to have my gallbladder removed. It's called a cholecystectomy. So they're out there. So if there's any type of abdominal pain, especially up in the upper right quadrant, you may want to suspect that it could be gallstones, especially if you find out in your sample history that they've just eaten a fatty meal. What triggered me was I had ate some Burger King. I ate some Burger King greasy fries, and that's when it triggered greasy food every time would trigger it. So couldn't get into the doctor right away, so I had to wait like a week or so. So I wound up drinking Gatorade and eating pretzels. No fat really to them, just a lot of carbs. Pancreatitis. Remember, the itis is inflammation of the pancreas. A lot of pain. You'll have a lot of pain like mid-epigastric, basically meaning right above the belly button, right below your rib cage. That's mid-epigastric or epigastric pain. And you can have a lot of issues with that because you can also still have a stone block the common bile duct, but you can have it block all the way down low, like you see right here, where the gastric juices from the pancreas come in down the common bile duct. So you can actually have a blockage there. Well, those digestive juices are meant to digest something. It too, excuse me, corona. It too can start backing up into the pancreas itself, the digestive juices, and it will literally start digesting and causing irritation inside the pancreas. So it's very important that if you have like epigastric pain, typically it'll radiate into the back, that might be a consideration. All right, so we're going to continue on. So we've got all the accessory muscles that help with digestion. So we've got the chyme coming in, the bile, digestive juices, all from the liver and the gallbladder and the pancreas. So you have all of this chyme and stuff now mixed in together. So you have the first section of the small intestines. It's only 10 inches long. They call it the duodenum, and it's basically it's from the pyloric sphincter, catches the common bile duct where everything comes in and mixes with the chyme, and it's about 10 inches long altogether. That's a section of the small intestines. It's just 10 inches, and it's called the duodenum. You now have the middle section. They call it the jejunum. The jejunum makes up about 2/5 of the small intestines. And the duodenum, its important part is the absorption of nutrients, especially the sugars, fatty acids, and amino acids. So basically, it's looking to get everything that you need. You need proteins, you need fats, and you need sugars. You store the fats, you use protein for muscle building and development, and you need sugars for your cells. That's why it's very important, the duodenum. If you've ever had anything called a J-tube or a JPEG for digestion, what they've done is the very top portion of the duodenum, they've actually put in a hole that you can actually put in like special like kind of nutrients or a nutrient solution that could be digested from the nutrients. So there's usually an issue with the stomach or the duodenum and mixing and digestion. So if you have any kind of digestive disorders that have to do with the stomach or the duodenum, they'll actually put in a J-tube or a JPEG, and it's into the duodenum, the very top of the duodenum, and then it's this digestive slurry that they put together that's mixed in and digestive that has everything that's essential for life. Then you have the ileum. The ileum is the lower part of the lower intestine, or excuse me, the small intestines. That is where you actually start absorbing some of the bile acids. They're looking for B12 and some of the red for the red blood cells to make red blood cells and nerve cells and stuff like that. So basically, they're looking to pick up the B12 there. That's what it looks like. So you've got your duodenum, and then you've got a JPEG. JPEG would go in here, and then the duodenum, and then the ileum. So what can go wrong with that? Well, you can have a hernia. A hernia is basically a protrusion of an organ or tissue. Anything can herniate, but it's a projection of that. But when we really talk about hernias, what we're really talking about is the small intestines coming through the abdominal cavity. And it can be a noticeable mass or a lump that actually comes through. If you've ever had, I've seen tons of people that have hernias. They're not super painful. They are kind of uncomfortable, but if it's small enough where it just kind of pops out and bulges out, you can literally just take 2 fingers and push it back in. I would not suggest you do that, but if you want to help the patient do that, that's fine. You may be called out for something like that. Where it gets bad is this right here. It's called strangulation. What happens is remember, everything in your body has blood supplies. It has arteries, arterioles, capillary beds, venules, and veins going and coming from. So with that being said, if it was to pop through the abdominal cavity, and it's significant enough where the pressure is pinched back on it and stops blood flow to it, you can actually have this start becoming necrotic. By necrotic or necrosis means death. So you will literally be killing this part of your gut. It can happen. So that's what you really want to look out for, is the fact that they may have a piece of necrotic intestine sticking out through the abdominal wall. Again, it may not be they can't push it back in anymore, and it might become strangulated. So that's very important. It can cause sepsis and all sorts of issues if it's not handled. Kind of talked about all that. One of the things that you want to look for is like kind of the reddish or blue discoloration. That's how you know it's probably strangulated. That'll give it away. Also, there's different types of hernias. It can come through the through the abdominal wall, usually around the abdomen muscles. You can have one that comes through the umbilicus, called an umbilical hernia. Inguinal, it's up here, up high, and it'll push into the pelvic cavity. You can have one that's lower that'll come into the femoral area. That's called a femoral hernia. So it doesn't just have to be that it pokes out from the stomach. You can actually have them in other places that they have to go back in and patch up and push back and fix surgically. You can have something called an ileus. An ileus is nothing more than a blockage in the GI tract. Basically, you got an impaction probably. Usually an impaction is lower GI in the colon, but you can have it where you have an obstruction. One of the things that you need to take note of is people that take pain meds, narcotics. Narcotics will slow down peristaltic movement. So you'll have it where the gut kind of dries out. It's not moving the food bolus as fast. So what'll happen is sometimes you can get stuff in and around it, or it'll start blocking up. It'll slow down peristaltic movement with taking these pain meds. So there you'll have this food bolus and everything else starting to back up behind it. So they'll start getting bloated. They'll feel like they haven't had a bowel movement in a while. You'll find that they have not had a bowel movement in a while. So you can have that there. Another thing is the peristaltic movement can stop altogether. I don't know how that happens. Don't ask me, but it can happen. So what happens is the peristaltic movement stops, and everything where it's at just sits, and it keeps piling in more and more, and it gets bulgers and bulging and bulging. And that's another thing. You'll have the gastric distension, which means their stomach will get larger because it's just filling up with poop in the small intestines, and they can't move it. So you can either have a blockage, or you can just have the movement of peristalsis stop altogether. I have seen it significant enough in a nursing home patient where she was so backed up with an obstruction that she was actually vomiting fecal slurry material because it was backing up so bad that it was actually having to back up out and go out the duodenum into the stomach and out her esophagus. It was horrible. All right, so you've got the ileocecal junction. So we talked about the small intestines, the divisions of the small intestines, the duodenum, the jejunum, and the ileum. So where it comes to the colon, also known as the large intestines, it's called the ileocecal junction. And it is basically, that's kind of a downgraded picture, but it's right here. Like basically, if you imagine all the small intestines here, and they come into this port right there. It's called the ileocecal junction. That's where they all come together. With that being said, there is something at the end. I'm going to go back and show you at the end, or at the very beginning, should I say, the end of the ileocecal junction. It's called the appendix. What happens is that it comes in, the fecal material comes in to the colon, and we'll discuss what the colon does here in a minute. But it can actually have some fecal material get lodged in the appendix. If any of the fecal material gets lodged inside the appendix, or anything in the fecal material that did not get completely digested gets into the appendix, like a piece of corn, something that did not get digested, it will cause irritation. Appendicitis is a bad mamma jamma because we don't know what the appendix is for. They have some speculations, but it's apparently something I know that evolution is taboo, but they believe that it is from evolution. That's the belief anyways, and it's something that we had that we don't need anymore. With that being said, though, what you'll have is you can actually have epigastric pain. Nope, don't have it. So what you'll have is you'll have pain, epigastric pain, or belly button pain. It will start in the center of the stomach, and then it'll start going towards the appendix, which is on the patient's right side. So as they have pain, it'll build more and more towards the right side to the point where they have right-sided pain. The bad part about this is that if it becomes so severe and so inflamed, it can rupture. So the bad part about this is that you can have the kind of hurting, nagging pain that's in the middle of your belly. You don't have to have it start in your belly, but it typically does. That's called the quote-unquote classic presentation. But if it goes, and then you'll have a patient that's got, it started in my belly, right-sided pain. You're like, oh, okay, sounds like appendicitis. You still have your appendix? Yes, I do. Okay, well, let's go to the hospital, and you're going to take them to a surgical center that can remove the appendix. The bad part, and I've had this happen, a patient says, oh my God, so severe pain. Gave him a little bit of pain meds, kind of took the edge off. They're like, yeah, I'm fine. And they went, oh, wow. Oh, that really worked. I feel so much better. And I'm like, wait. I gave you a little bit. That shouldn't have been like automatic instant relief. What can happen is this can get so severe, so inflamed that it ruptures. If it ruptures, you're going to have all this stuff come loose. And if there's any fecal material in and around this area, it's going to go into the abdominal cavity. That's bad. So if you want your patient, unfortunately, you're not saying you want them in pain, but if they're still in pain, that's good. I hate to say it that way, but as long as if it is truly appendicitis and they're still in pain, that's a good thing that they have pain. You want them to have pain. And you can manage as a paramedic, your paramedic partner should be managing the pain, their pain, and trying to get them to a comfortable level. But when they become pain-free and it's instant, just like that, that's when you need to start worrying. Something has happened, like it is ruptured. So that's where you really need to let the hospital know, like, hey, he was like 10 out of 10 pain, right-sided pain, and then all of a sudden he's had instant relief. We gave him pain meds. He was fine with the pain meds. Now, it can be that you give pain meds and the person is just very sensitive and they know extreme relief, and that's something to be wary of. But again, the extreme pain and then not the extreme pain, or the relief of the pain, that's what you need to be concerned with. Gastroenteritis is just basically inflammation of the stomach and the intestines. These are usually viral or bacterial in nature. typically what you really have is you'll have a diarrhea with it. So gastroenteritis, usually if you come in with diarrhea, I'm going to say I've had diarrhea for a week or so. I know I had that issue last November, actually, and I swear to God, I thought I had C. diff. And I went in and I gave them a stool sample. I felt bad for the people, but and they're like, yep, just gastroenteritis. You had diarrhea for a week for no real cause. They basically said I had some sort of viral bacterial infection. They'll do a culture. They'll take they'll take the fecal material, they'll do a culture, and they'll determine whether it's bacterial or viral. If it cultures bacteria, fine, they'll give you antibiotics. But I think mine was viral. It was just a really nasty bug. Crohn's disease. They really don't have a lot of information out on Crohn's disease, but it's a big thing now. They used to just chalk everything up to gastroenteritis, but Crohn's disease has to do with severe swelling in the actual the bowel itself. A lot of inflammation. Again, there'll be bloody stools from the severe inflammation. There'll be blood in the stools. But they'll also have like a lot of gastric pain, a lot of diarrhea. If they don't have the diarrhea, then they're trying to move a food bolus through, and it's just very, very painful, extremely painful. And that's kind of what they're talking about, the normal intestines. But then you'll have the severe, significant inflammation of the actual tissue that's in the inside of the actual intestinal wall itself. All right, so now we talked about the small intestines and some of the things that can go wrong with it. Now we're going to move on to the colon. The colon has a separate job, also known as the large intestines, has a separate job. It does not do any of the nutrient absorption. That is all small intestines. When it comes into the large intestines, aka the colon, what is looking to happen is water absorption. To be able to move your food bolus through your small intestines, a lot of fluid and water is dedicated to the intestines itself. With that being said, you make this kind of fecal material slurry. If you're having gastric issues, the colon doesn't hold it for very long. If you're trying to evacuate your bowels, like if you do have a bug or a virus or something and your body's like, oh, let's get it out, it will evacuate the bowels without having the colon. That's where you get your diarrhea from. With that being said, though, the colon's main function is to go ahead and absorb the water back. It's basically looking to recycle the water so you don't get dehydrated. That's why when you do have diarrhea, you do get dehydrated very easily. These are the portions of the colon itself. You've got remember I said the ileocecal connection right here. They call it the cecum, the small area. But then you have the ascending colon that goes up, transverse colon that goes across. You have the descending colon that goes down, and then the sigmoid colon comes out and into the rectum. Then you do have bowel leave the anal sphincter. So one of the things that can go wrong is called diverticulitis. Diverticulum are pouches that form all along the colon wall. Lots of people have this, believe it or not. About half the people over the age of 60 have them. So you have a good chance, a 1 in 2 chance of getting diverticulum. It happens. Most people live with it. They don't really know anything about it because as long as they're eating things that don't catch inside the little pockets here, and this is what it looks like. You got little pockets or outcroppings. As long as nothing gets caught in there, like any fecal material or anything that's undigested, like corn, gets caught up in these and blocks those or blocks fecal material in there so it's not moving, it's okay. Where you start having diverticulitis and you start actually having issues is where it does get blocked in some of the areas and it starts having infection set up, and then you start having septic like symptoms like fever and stuff like that. So and then it becomes irritated, you'll have some diarrhea, so it does get very, very bad. So again, diverticulum is something that people live with. There's these outcroppings and pouches, and that you can have this and not have too many issues. So we talk about upper and lower GI tract, and there's a reason for that, especially when we're trying to identify where a potential bleed might be coming from. So there's so much literature out there that it's kind of hard to say, but basically what they're saying, upper GI is the esophagus, stomach, and the duodenum, or the duodenum, however you want to say it. That's kind of the upper GI. They're saying that the lower GI is anus, rectum, and the colon, or the large intestines. That's what they're saying is lower GI. And then they do have a middle GI, and that's the small intestines from the jejunum and the ileum. That's what they say. It's like the middle intestines. But the idea is to try to locate a bleed. But just by stool, you can probably identify not exactly where a bleed is, but identify which way you need to go, because they will do a scope, endoscopy. They will look for a bleed in a person, and they'll try to figure out where it is if they can stop it. One of the things that you need to know is that you can have gastrointestinal hemorrhage. You can have bleeding. So there's something called hematochezia. That's where you have blood, fresh blood, mixed in with fecal material. Let me just tell you that if you ever smell a GI bleed, regardless of whether it's an upper or lower GI bleed, digested blood smells horrible. You will not forget the scent or the smell. It will always be around you, and every time you do smell it, you'll be like, I know what's wrong. You have a GI bleed. So the hematochezia, that means typically that it's going to be a lower GI bleed. That's because the blood has not had time to be digested and absorbed in. So you have fresh blood that's not getting absorbed, because more than likely it's probably in the colon somewhere. And remember, the colon doesn't absorb anything. It just takes out fluid and reabsorbs the fluid. If it's dark tarry stool, also called melena, is dark and tarry. It's pasty. It's really gross. It's thick and sticky. If you ever wind up putting your hands in it, which hopefully you never do. But with that being said, that's more of an upper GI bleed. That shows that there's signs that there has been digestion done to the blood itself. So therefore, it has gone through the stomach, into the duodenum, into the small intestines, and been digested out. Gross, I know, but this is what you're looking at. That'll be your hematochezia, fecal material mixed in with a bunch of blood. Now let me tell you, a little bit of blood goes a long way. A couple drops of blood will turn this whole entire toilet red. It happens. So people may call you with a GI bleed, and as you'll check their signs and symptoms, as long as they're not showing signs and symptoms of shock, they should be okay. That's the melena. That's what you really want to be concerned with. If they start having dark tarry stools, that's what means they've got an upper GI bleed somewhere, and they are going to probably need some treatment. At least something, maybe some medications to be able to stop the bleeding. One thing I do want to remind you, we talked about it in pharmacology, basically the absorption of the small intestines of the nutrients, even in the large intestines and in the spleen and all over in the abdominal cavity. There's something called hepatic, aka portal circulation. Hepatic circulation, portal circulation, same thing. Everything, there's a venous system, just a venous system, that takes all the nutrients and all the fluids and everything back to the liver. The liver is the big filter. There's a reason for that. Along with that being said, though, you have vascular or venous circulation throughout the whole entire digestive system, from the esophagus all the way down into the anal area. There is venous circulation. It is absorbing up whatever it's supposed to absorb, whatever is responsible for in that area. With that being said, you can have venous engorgement that cause something called hemorrhoids. Hemorrhoids are typically veins that get engorged in around the anal sphincter, and they can and do sometimes rupture, depending on how bad it gets and how severe it can become. Hemorrhoids are not fun. I know because a friend told me they're not fun. Anyways, they're not fun. They do hurt. Very painful. And they can rupture. They don't have to just be on the external portion of the anal sphincter. They can actually be on the inside and the rectum too as well. So they can rupture, causing a GI bleed. I've had this happen to me before, where it's like, I've got a little blood in my stool. That's not good. And I tell somebody, because I'm always afraid that if I just don't tell anybody and I have this massive GI bleed and I code, nobody's going to know what the hell happened to me. But with that being said, you may get called out for this. They have blood, and you're obviously probably not going to be looking or asking about hemorrhoids. You can ask about hemorrhoids if they have them. They may not know that they have them, especially if they are up in the into the rectal cavity. but they can rupture and cause hematochezia, and from there, it usually goes away in about a day or so. So you may have a couple of bowel movements where there's blood in it, and it will taper off, and it'll go away. So that's good news. On the other side of this, you can have something called esophageal varices. So, again, the venous system that's surrounding the esophagus, the venous system will become engorged. It'll become engorged to the point where it makes difficulty swallowing. Typically, when you start having hemorrhoids, are just fluid back buildup. It could just be venous engorgement. It just happens. Also, the fact that you have that sphincter cavity there, it just becomes weak in the lining wall. But typically what starts causing esophageal varices is the fact that you have cirrhosis of the liver. Typically cirrhosis of the liver comes from drinking. That's usually, they call it the drunk man's disease, because it usually winds up destroying your liver. Remember, toxins go through the liver. The liver can convert and help purify alcohol. But you get that drunk effect because you've exceeded the amount of alcohol the liver can start processing. And so what happens is that it starts spilling over into the bloodstream, which affects your neurological function, and you become essentially drunk. So this is something that you'll see. Usually if there's esophageal varices, there's something wrong with the liver, usually cirrhosis of the liver, and the liver can't process fast enough, so it starts backing up in the hepatic portal circulation, and you'll see it in esophageal varices. And you'll probably, if they have this issue, they probably also have the hemorrhoids as well. The spleen. The spleen has no digestive function whatsoever. The spleen is more along the lines of a blood reserve. It will actually take blood and kind of hold it and keep it there. It helps filter out the blood, some of it, and it helps produce antibodies. People do have a splenectomy, which means that they have their spleen removed and they're okay and they live just fine. But still, it is cause for concern as far as like in a trauma. Again, when we talk about abdominal trauma, we'll talk about it then. But other than that, that's really just what the spleen is for. Urinary system. So the urinary system is basically to take waste out of the body and help you pee it out. Again, the digestive system does have waste, but it's waste from what you put in. It's the same thing with your urinary system, but it's also taking the waste typically from the liver, and it's usually something called urea, hence the word urine, because you're taking the urea and creating a liquid or mixing it with liquid and fluid and sending it out the body. So you got kidneys, you got two ureters, you got a bladder, and a urethra. Kidneys are the filtering process. One of the things that you do want to know for endocrine functions is you have the adrenal glands up there. The adrenal glands release adrenaline, which jack your heart rate up, start your they say flight or fight response. Either you're gonna notice something really bad happening, you're either gonna run the hell away really quickly, or you're gonna go ahead and stay and fight and deal with it out. But anyways, regardless, you're gonna need adrenaline to jack you up, start your heart rate up, get your blood pressure up, stuff like that. The reason why they're stuck up there is because, believe it or not, the kidneys get about 25% of the circulating blood flow. 25%. Think about that. 2 kidneys, 12.5% to each kidney. That's a lot. But the whole idea is that they're trying to send a lot of blood to them to get them filtered and cleaned out. There's things that I want you to pay attention to. I'm not going to gig you too hard on the anatomy, but you do need to know that there is a cortex that is surrounding, and it's got a lot of the blood vessels in that area. You've got the medulla, which in it has something called nephrons. These nephrons are the little tubules that will go ahead and start filtering out. You have hundreds of thousands in this medulla. All these nephrons are in there. And then what it'll do is it'll start draining out the urine into this, they call it a coccyx. And it's where all the urine gets collected and then it starts sending down into the ureter. Again, major function is to go ahead and eliminate waste. That is what it does. And it mainly takes a lot of the waste from the liver. So what can go wrong? You can get something called kidney stones, also known as renal calculi. And basically the kidney or the kidney system is called renal and calculi because it is made of calcium. They're calcium deposits. And they're formed. And the bad part is the longer they sit, and the more you have this issue, the bigger they'll get. So typically what can happen is, I've had these two. I really hate to say that I've had a lot of these issues, but I have. You'll get a stone that forms and it'll pass. Some are so big that they can't. They do something called lithotripsy, where they put you in and they use sound waves to break it up. But what happens is that you'll go ahead and it'll finally sit somewhere, and then it'll finally drop. When it drops, what you're using now to move it is all the pressure backs up and builds up, making urine. And that pressure starts building and pushing it forward. That's why it hurts. And where people will have is right up underneath the backside of their rib cage on their posterior side. They'll have what's called flank pain. It's kind of out there mid-axillary. They'll have right or left flank pain. And they'll say that they feel like a tearing or burning sensation, and they'll feel it, and over time they'll feel it move. And it does move because the stone is being pushed down and out, and it is moving. You can also have kidney failure. There's different types of kidney failure, and believe it or not, there's different stages as well. I want you to pay attention to the types of kidney failure more than the actual stages itself. You can have acute kidney failure. It's very reversible, especially if it's caught right away. But there are issues that you can have that are going to cause chronic kidney failure. Like, you can have kidney failure that's just not going to reverse, not going to fix itself, and it's going to be this way for a long time, and then you'll eventually have to go on dialysis. We'll talk about that here in a minute too. You have something, I know the slide's kind of blurry, I'm sorry. There's something called pre-renal. Pre meaning before. Before it gets to the actual kidney itself, you can have like a severe drop in blood pressure, heart rate goes down, you can have injury or an illness, and what you can have is you can have that affect the kidneys. You're just not getting enough blood flow to get blood flow there. You can be dehydrated. That'll affect kidney function as well. So you have a bunch of things or factors that can affect it before it actually gets to the kidney. So you can have pre-renal. Pre-renal failure is pretty okay to have. If you're going to have it, that'd be the one I'd want, because it's reversible. You can fix that. You'll get better. You'll feel better if you've got an illness, or if there's an injury. More than likely, hopefully, the injury will be fixed. If you're hypotensive or dehydrated, you can use fluid to build it back up and start being able to restore blood flow to the appropriate areas, including the kidney. Intrarenal is usually direct damage to the kidney itself. That's the one I would not want to have. It's usually bad juju. It can be caused by actual trauma to the kidney itself, like actual physical trauma. You can have toxins or drugs or infections inside the kidney itself, which usually comes from a UTI, which we'll discuss, because UTI usually starts down low and it works its way up. But if it works its way up, you can have the kidney itself actually become infected or inflamed, and that's when things start going south. You can have post-renal. So outside of the kidney into the ureter is where you're going to have post-renal. And it's usually come from like renal calculi or kidney stone, some sort of obstruction. It could be a tumor, anything of that nature where there's an issue down here that's blocking urine up, and it's not being able to push the urine out or get urine out even better than it was before. There's different stages. They measure it based on the GFR, which is, I really forget what it's called, but they do blood work and they monitor how much urine you're putting out. And then basically based on that is when they start giving you different stages. Usually where you're going to start having kidney function and you start having dialysis is usually sometimes stage 3, but really stage 4 and stage 5. Stage 5 is like end stage. If they're in stage 5 kidney failure, it's end stage stuff. And it's usually handled by the nephrologist. The nephrologist who's measuring all this and keeping track of kidney function will give them their stages and tell them how bad it is. Typically people need to be dialysized for that. If you don't know what dialysis is, I'm going to explain it here in just a moment. But it's basically having kidneys outside your body. Dialysis is basically where you have a machine that will clean the blood for you. And it's a nasty process. And some of the problems that you'll have and you'll face is the people that are in like, stage 5 renal failure or stage 4 renal failure. They go 3 days a week. They'll go Monday, Wednesdays, and Fridays, believe it or not. Some of the people that are not at the high stage, end stages, or they'll go usually the Tuesdays and Thursdays. So you'll get somebody that's in like stage 4 or stage 5 kidney failure, and the Monday is a holiday, so they had dialysis on Friday, and here they are going to have to wait 5 days. Well, some people can't wait 5 days. They can only wait a couple days. And so they're waiting over the weekend, and then they skip a treatment day, or they just decide not to go on the Monday or whatever day, and here they are, 4 or 5 days in, and they start having symptoms of they're getting altered. They haven't had their dialysis, or they didn't go. They're refusing to go for whatever reason, and then they have issues, and they need to be dialysized very quickly. This is what it looks like as far as the machine. I'm going to talk about the actual the fistula that is created to be able to do this. But the machine itself takes the blood in, and it's got some sort of cleaning mechanism, and it cleans it and takes it out. And sometimes also with dialysis that you can have they take out too many nutrients. You can have you have elements. Remember we talked about sodium, potassium, chloride. All of these elements are inside your blood. They can pull off too many, and that can cause heart arrhythmias, which I think we asked in the group or was asked in the group chat here a while back. Yes, an irregular heartbeat. They can have issues with that. So they've got to be monitored before they leave. Hopefully, they're monitored before they leave for their blood levels of those things. So an AV fistula is basically going to take an arterial or an artery and a vein, AV, artery, vein, fistula, and they put them together. Now, they can do it 2 ways. Either way, it's still a surgical process. They can literally take a vein, cut it, and stitch it into an artery itself, or they can actually put a graft in. And the graft is like a plastic tubing that goes in, and then it will be placed under the skin. Usually you'll see them look something like this. The reason why it looks like this is they have super venous engorgement from that. And they don't always last. Sometimes you'll actually see people that have 2, 3, or 4 of these, 2 in one arm, 2 in another, and only one's good. They don't take out the fistula because it's just too much of a pain in the ass, I guess, to do it. I don't know why they don't take it out. But you'll see like this severe engorgement, and that's typically where the fistula is. If it's a graft, you'll see the U shape under there, and it's like, whoa, that's crazy. And then you'll see the venous engorgement, or the engorgement of the vessels back there. Again, some adverse effects. They can pull off too much of the electrolytes. You can have a shift in sodium, potassium, chloride. Muscle cramps can cause from that. Nausea, vomiting can come from that. You can have hemorrhage at the site that they can't control. If they pull out too much fluid, they also try to regulate the fluid that gets pulled out as well. If they pull out too much fluid, you can have hypotension. And you can have infection or issues at the actual puncture site that they actually go in and they puncture in. So that's always something you need to be wary of. The reason why they stress this pretty hard is the fact that some people, when they first come out of EMT school, and I'm not saying that's going to be you, but they might go into non-emergency care. Not a lot of non-emergency care or non-emergency transport companies actually pay better. That's the good thing. You work 12-hour shifts. That's another good thing. But what they really do is they wind up transporting a lot of people to either medical appointments, doctor's appointments, stuff like that, or they wind up taking a lot of patients to dialysis. So you may have some patients that get taken to dialysis. That might be you. You might be bumping the dialysis to home, just rotating people in and out. So that is always a possibility. So what they say is basically manage the care, control bleeding. If you do work for these non-emergency transport companies, their policy is to have you call 911. Even though you're an ambulance, you're not supposed to transport these people other than to their home or to dialysis. If there's an issue, you call them like you get ALS care. They talk about the urinary tract stuff. They show that, again, you've got your 2 kidneys, 2 ureters or a ureter. You've got the bladder itself, and then the urethra. They put male urinary system in, but here you go. There you go, ladies. There's the female, male, female, male. So there you go. You're not left out. You can have something called cystitis or bladder infection, commonly known as a UTI, urinary tract infection. It usually comes from either bacteria or toxins getting into the urethra, the basic point where urine leaves the body. So, with that being said, who gets it more, men or women? Mainly women, because their urethra is much shorter, so it can get into the bladder and start really developing a lot faster. So, that's cause for concern. Typically, and not to be gross, but it typically comes from improper wiping or improper hygiene when it comes to fecal material. That's typically what it is. That's why when they tell you when you have a baby girl, I learned this when I had my daughters, you wipe from front to back, not from back to front. You wipe away. You wipe the fecal material away from the possible origin of the urethra. One thing I do want to bring up right here, though, in the elderly, especially in elderly females, if you have one, they're like, man, you go to the nursing home, or you go and their mother lives at home with them, or they're even though they live alone, then you have a family member tell you, like, look, they were fine like an hour ago, and all of a sudden, they started spiking a fever a little bit, but like started acting crazy and not in the right mind. It happens. What you need to think then is an elderly, and sometimes to elderly female patients. It can happen to male patients because male patients do cath. So if they're introducing a cath into their urethra to be able to urinate, you need to think that might be a possibility as well. But they start acting crazy. They start acting out and talking out of their mind. So if they feel a little warm to the touch, and again, they don't have to have fever, but if they do, that is an indication. But if they were fine 1 minute, this is not their neurological normal. You got somebody on scene saying, I don't know what the deal is. This is not right for them, and yet here we are. I'm thinking it's a possible UTI. They talk about the reproductive system. They do have female reproductive system. I will tell you that I took it out. And the reason why I took it out is because there is a whole chapter, ladies, designated to your reproductive system and how it works. Guys don't get this luxury, so they're going to get a little spotlight here. I'm not really going to go over it. I wish Kazmar was here because Kazmar would probably have some really great music and a really good presentation. But you talk about baby gravy and stuff like that. But anyways, I digress. We're going to move on because one of the things that I want you to be wary of is something called a testicular torsion. A testicular torsion is literally the turning. Somehow the testicle gets spun around. I have not had this, thank God. This is one of the things here in this chapter I have not had. But I've been on not a call, but I've been on clinical at a doctor's office that was a pediatrics office, but a young man of the age of 16, who's still technically a pediatric, came in, and he was a wrestler. And he was wrestling like on a Saturday, here it is, Wednesday or Thursday, and he has got just severe swelling blue testicle. And his parents are obviously concerned. What happened? Well, apparently, while he was wrestling, it got knocked around because of one of the moves that they use, and he had a testicular torsion. And the doctor right then and there was able to unspin it and restore blood flow, and the kid started feeling better. So it was very, very weird, very, very odd, but it does happen. We're going to talk about something, and took me a while to kind of wrap my head around this, but there's the abdominal cavity itself is lined with something called a peritoneum. The peritoneum is a lining that holds everything together. Imagine if like you just had your intestines are just sitting there and gravity would just pull them wherever if you lay it on your side, it would pull them. Well, what this peritoneum is kind of like a saran wrap. It saran wraps and holds everything together, and it kind of anchors at certain points in the body. And by saran wrapping, anchoring everything together, it holds it all together nice and neat. So everything's able to work together. Because imagine if it's just your small intestines just fell with gravity while you're standing, and now you can't. It's just like down into a pile of a garden hose, if that makes sense. But this peritoneum is like a saran wrap lining that holds everything together. And from a sagittal view, this is what you're looking at. So you've got it, it's wrapped in and around. When you get this PowerPoint and you're looking at this through this lecture, you'll see that it's all just kind of wrapped around, and it's anchored to the actual abdominal cavity in different places. So it holds everything up together, and it just holds it nice and neat together. There's a flap, believe it or not. I'll go back and I'll show you. There's a flap that covers most of the upper part of the abdominal cavity, and it's called the greater omentum. So there's also a flap that covers it. So that's pretty interesting. So So, with this being said, the peritonitis, you can have inflammation to the peritoneum itself. With that being said, it's usually caused by some sort of foreign material that is not supposed to be in the abdominal cavity. Fecal material, blood, whatever, gastric juices, whatever. It's in there, it causes irritation, and it hurts. It's usually global abdominal pain, and the patient does not want to be moved. That should cue you in. If they're like, don't move me, don't touch me, please don't move me, and if you move them and help them slide over the stretcher using a sheet, and you lift them over just gently, like you just take them and lift them gently over, and they're like screaming and writhing in pain, that should clue you in that this might be peritonitis. That's typically what it usually is. Most abdominal pain, people can usually point with one finger into an area, but with peritonitis, it is global across the whole entire abdominal cavity, and they usually have just severe pain just from movement. The thought of moving gives them pain. So we did talk about dialysis, but there's another way that they can do dialysis, especially if there isn't really much of an issue, but they need to do dialysis, and they don't want to do it with the fistula, and they're not in any type of, like maybe stage 2 or 3, they can do something called peritoneal dialysis. And what happens is, it's a setup at home. They do have a catheter put into the abdominal area, into the peritoneal space. And what happens is they put this fluid or saline solution in, whatever this is, goes in, and then it sits, and then it works with a vacuum pump and kind of pulls it back out and stores it in there. So they're able to actually kind of get rid of toxins through the peritoneal space, because what they're doing is they're trying to intercept the toxins, some of them, before they go to the liver, become urea. Hopefully that makes sense. There is an area behind the peritoneal lining called the retroperitoneal space. Retro meaning behind. One of the organs that is retroperitoneal is the kidneys. So if you see something that says organ that is retroperitoneal, there's some other things, excuse me, corona. There's some other things that are retroperitoneal, but really truly when they talk about a retroperitoneal organ, it's going to be your kidneys. I want to throw that in there because you may see that on a test. I'm not saying my test, but I'm saying like I've seen this on registry before. All right, so let's get into acute abdominal pain. Basically what that means is they have an onset of sudden abdominal pain. All right. Typically they may have an underlying history that you might be able to get out of sample. And they'll say, yeah, I've had this and going on, and I think it's just getting worse and worse. Okay, fantastic. So you kind of have a diagnosis from a doctor. Because like I said before, abdominal pain and abdominal issues are usually not acute. They're not acute as in, like, all of a sudden they're fine, next thing you know, they're doubled over in pain. Yes, that can happen. I've seen that happen as well. But it's usually like something like appendicitis or something like that. Usually like a blockage or a bowel blockage or any of these other things usually build up and take a while. There's one thing in the abdominal pain that you'll have is called referred pain. And what that means is that you may be hurting in this area, but you might actually be hurting somewhere else. Like with chest pain, cardiac call, they'll have like left shoulder pain, left arm pain, left neck pain. That's called referred pain. That's pain that's not actually in the localized area, but it is somewhere else in the body. So there are some things like if you have... like I said, like you have appendicitis, it usually starts in the umbilicus area and then it goes in. If you have cholecystitis, if you have an infection or gallstones and it's really bad, you can actually have like right shoulder pain as well. So there's some things that you have that can have referred pain. So they can, can clue you in as well that if they have this type of pain and it's going, and they also complain of like some shoulder pain, it could be something else going on as far as there might be an abdominal issue. And there you go. There you have it. That's the referred pain for gallbladder pain. One of the things that we do need to bring to light is the aorta. The aorta passes through the abdomen. It's called abdominal aortic aneurysm. Is something that can go wrong. What that is basically you have the rupture in the lining. Remember we talked about what an aneurysm is. You can have this anywhere, and they call it a triple A. Let me just tell you can have them also in the thoracic cavity as well, but really we're talking about the abdominal cavity, so here you go. With that being said is that the lining ruptures, and eventually this will rupture. They do some treatments. They do try to put stents in to try to keep that from happening. But with that being said, is eventually, typically, they will rupture or they'll leak. Hopefully leaking is the better option of the two, because if this thing is just split open and rupture, let me tell you, you're dead in about 30 seconds. Gone. I've had a car wreck that actually wound up going to the crime lab, and they did an autopsy, and it wound up being that he had an aortic aneurysm that ruptured and he was driving. So the car crash didn't kill him. It was the aortic aneurysm. All right, so let's start with your scene safety. Obviously, they're talking about scene safety. The big now pushes, if anything, respiratory, the big major PPE stuff. Just be mindful of the call that you're on and the PPE you're needing. What you're really concerned with is, if I know we haven't talked about it, but shock trauma signs. You're going to have pale, cool, diaphoretic skin. Like, they're going to be sweaty, cold. They're going to be tachycardic to start with, and then in the late signs, they're going to become bradycardic. They'll be tachypnic. Basically, if they have a tearing pain in their abdomen, that might be the dissecting aortic aneurysm spreading. The odor, again, with the gastrointestinal bleedings. Once you smell a GI bleed, you'll never forget it, I promise. Airway and breathing, it's usually associated with the pain or the amount of level of pain that they feel. So you'll have, like, they might be breathing shallowly, or they might be guarding because they have the abdominal pain. It hurts to take a deep breath. It may not be that they need the oxygen because they're having breathing trouble. It might be they're just not taking a deep breath enough, and you need to put them on a little supplemental O2. Typically, the airway is not obstructed unless there's vomit or emesis. That's when you need to be wary of the airway itself and protecting the airway from that aspect. But usually, typically, you're not going to have airway issues. Transport decision. Circulation. Check your pulses. Find out if they're tachycardic, bradycardic. You'll also be checking the skin. One of the things that you can ask about if they are having abdominal pain. Hey, have you been able to pee and poop okay? Anything, do you have a burning sensation when you urinate, or any black tarry stools, any blood in your stools? And people don't think to tell you those things, so you may have to ask those things. In your sample, one of the things that you do want to have be wary of is that they don't put it here, but pre-existing conditions. Any pre-existing conditions that are there, that's what you want to know about, because they might have Crohn's disease or something of that nature. So that being said, belching or flatulence, that might be an issue. Nausea, vomiting, if they change in their bowel habits, if they start having more frequent diarrhea, any chest pains with it, those kinds of things. So when you do your physical exam for an abdominal patient, let's just say the screen is the 4 sections or the 4 quadrants: right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. Wherever the pain is, wherever they have the pain, they're usually going to be kind of in a quadrant area. You don't want to start where palpating there. One of the things that you're palpating for is you're looking for gastric distension. Like I said, some of these disease processes have gastric distension, and typically that's going to be global. You'll notice that throughout the whole thing, throughout the whole abdomen. But if you're going to palpate, you're looking for maybe a bulging mass, which could be your AAA. Or you're just looking to feel, just to see if there's anything different out of the ordinary. So when you go to do a palpation, start on the opposite, complete indirectly from there. So if it's right upper quadrant pain, take your 2 hands together, you're going to palpate down here. Oh, does that hurt? No, a little bit. How about here? All right, how about here? And then palpate the quadrant that's hurting. So start from the exact opposite quadrant from where they have the pain, palpate there, kind of palpate in and around, and then go to the one with the pain. More than likely, they're not going to let you touch the one that's in the pain. But with that being said, start from the exact opposite. And then the more abdominal assessments you do, you're looking for soft, not tender. It could be tender upon palpation, meaning it hurts. And again, gently palpate. Don't smash in hard. Just kind of take your hands and just kind of come in, rub and feel, and kind of rock your hand back and forth and kind of rub and feel a little bit. Not hard, not forceful, kind of gently. This slide is useless, but I added this, orthostatic BP. How you can tell And we'll probably get to, again, in shock trauma, having to do with bleeding or having to do with hypovolemia, meaning there's not enough fluid in the vascular system, cardiovascular system, in the blood vessels. What you do is you can have them either lay, you can start having the patient lay down, especially if they're laying down. So what you do is you take their blood pressure. That's your baseline. So, and you take their heart rate. You sit them up. You take their blood pressure again. If you have a decrease in 10, because what's supposed to happen is when you sit up, your heart rate is supposed to rebound and it's supposed to catch. Your heart rate increases and it sends your blood pressure. Your blood pressure is going to increase. So with that being said, they should not have a drop in their blood pressure. Maybe a little bit, okay, that's fine. This is what I found online, 20 millimeters of mercury for the top number, 10 millimeters of mercury for the bottom number. So a drop of 20 systolic or a drop of 10 diastolic within the 3 minutes of standing. So basically, you're going to go ahead and sit them up. Or if they're in a sitting position already, take their blood pressure. That's your baseline and stand them up. You'll know if they have orthostatic hypotension when you go to stand them up. When you go to stand them up, they'll literally want to pass out. They'll want to go, I need to sit down. I need to lay down. I don't feel good, guys. So that's when you know there's something wrong. Now, I'm not saying that it could be a hypovolemia issue, but typically sometimes that does point that out. But your book says 10 and 10. I've seen 10 or 20 and 10. So be wary, be mindful, but just understand that if there's a drop in pressure and it's significant enough, then you need to think that there might be a bleeding issue. All right, frequently reassess. If they're showing signs and symptoms of shock trauma or shock, it's not going to be from trauma, but shock, every 5 minutes, and then you start looking to do your interventions, ALS intercept. When we get into your advanced stuff, you can do lines, hang fluids, start working on getting their blood pressure up. Really, you can't treat the underlying causes in your ambulance for abdominal pain or abdominal issues. You can treat for the hypovolemia with fluids. Again, that's going to be an advanced skill or higher. The only thing that you really can do is treat for is the pain. Like I said, when we're talking about the appendicitis, you can treat for the pain. Pain is what you're looking to treat with, and that's going to be a paramedic skill. And that, my friends, is the end of this lecture. And yeah, have a good day.